you want me to? Okay. My MRI said that the tumors are rim enhancing but necrotic in the center. So which procedure would work the best for tumors like that?
Okay. You bring up a good point because actually there is combination therapy, and we do like to do potentially both procedures. But again, it depends on the number of lesions. But if you were fortunate enough to have one, let's just say one lesion, and there was some residual rim enhancement.
Call a surgeon.
Oh yeah, call the surgeon. I mentioned
Next.
that earlier. That if you
Next.
that image on the top, if you had that one rim enhancing lesion, you should call your surgeon. But if you have multiple lesions, let's say you had 3 lesions, and they might involve both sides of the liver,
Call a surgeon.
call your surgeon. But if your surgeon said that you were not a surgical candidate,
Call your radiologist.
call your interventional radiologist. And we would potentially offer 2 things. One, we might, again, it's very theoretical. It's a very simple way that we like to think about it. We would try and kill the tumor from the inside out and from the outside in. So we may offer both embolization and ablation in a situation like that.
There is also another option. You can go to Europe and get lutetium-177 treatment, or perhaps within 6 months you may be able to get that here. So that this will be an additional way of treating such tumors.
Okay, Dr. Werner, who I think is probably the guru of all gurus, let me play the devil's advocate for 1 second. If you have regional disease, why would you take a systemic approach? I understand if you got bone lesions and liver lesions, now we need PRRT. But tumor limited to the liver, would you spend that bullet that you don't quite need that bullet yet?
Since carcinoid or other neuroendocrine tumors extremely rarely arise in the liver, even though that's the only place you can demonstrate them, it is very likely that there's still some microscopic nests of tumor cells outside the liver. I agree, if it's the dominant place where tumor is, then targeting whatever treatment's going to be used to the liver is a prudent thing. But systemic treatment is not a bad idea because it also gets the tumors, or the baby ones that aren't seen, which are outside the liver. Now, the overall guiding principle, though, is multiple ways of treating sequentially. The question is, what should the order of the sequence be? No one form of treatment, except surgery for cure when you can really get it all out, is going to be adequate. You can't just do one thing, whether it be hepatic artery embolus, chemoembolus, radioisotope, or whatever. Nonetheless, you don't just do it, shrink your tumors, and then sit back and do nothing until a year, 2, or maybe 3, when they recur. You follow it with some other treatment to continue that effect that you started, and to also affect any tumors that are more outside the liver but not clearly recognized. The importance is that treatment must be customized in each case, and you cannot just do one and then wait. Don't wait. It should be treated in a proactively way to prevent any further or deter any further progression. Again, a great deal of judgment is involved because we don't want the treatment to be so harsh as to impact badly on the quality of your life in the meantime. I think we're all in agreement. Now, I have a question from the floor here for Dr. Waltring. Is there a chance of carcinoid crisis during surgery? And I suppose implied is, what do you do about it?
Again, let's talk about where does your tumor arise from. If you have a pancreatic islet cell tumor that makes insulin, you have an insulinoma. The chance of you having a carcinoid crisis is 0 because you don't have a carcinoid. If, on the other hand, you have a carcinoid of the pancreas, which is pretty damn rare, or a carcinoid of the small bowel, or a carcinoid of the appendix, less so, but not 100% so, hindgut or foregut lesions. If you have something that's attributed to carcinoid, whether it's in the pancreas, the bowel, wherever, and we were going to operate on you, the good news is that somatostatin analogs are so non-toxic, and we would start treating you 2 hours ahead of surgery. We'd give you a bolus of 500 micrograms of octreotide acetate. We'd start you on a drip of 500 micrograms an hour, and then depending on the surgery, in the recovery room, we'd start tapering it off. Or if you had a 16-hour operation with, resection of the liver, resection of primary, debulking of the mesentery, et cetera, then we would taper you probably over a day. But let's say you had something simple like your gallbladder taken out, then we'd probably taper you over about an hour.
Let's embellish on that a little bit. Supposing it's not going to be real surgery, but just a trip to the dentist for dental extraction or some other procedure where he might inject some local anesthesia.
Again, your dentist is a healthcare provider. That means he has to understand the disease that you have. One of the worries when you go to the dentist is almost all the dental anesthesias are pre-made in a tubex, which means they've all been mixed up together and there's a needle on it, and they just put it in a little holder and zap you in the mouth with it. Almost all those, quote, Novocaine kind of things have something called epinephrine in it. And the epinephrine is used to decrease bleeding and to prolong the length of the anesthetic, how long it works. Epinephrine, especially if they get it into a blood vessel, can provoke the release of serotonin and the vasoactive amines from neuroendocrine tumors. So you got to tell your dentist you can use anesthesia, but I don't want you to use anesthesia with epinephrine. And B, I tell most of my patients, if it's something simple like a cleaning or a simple filling, probably do nothing. If it's a root canal or something major, give yourself a rescue shot of maybe 200 to 300 micrograms an hour before you go to the dentist. But tell him, if I collapse and turn red like a lobster and get me to a hospital, don't just sit there and think that I'm just having an allergic reaction because I could have a carcinoid crisis. Most dentists are fascinated by the concept of carcinoid. They've never heard of it. They're dentists. I mean, they know all there is to know about root canals, but they don't know anything about carcinoid. So when you include them in their medical discussion, they really love it. They just sop it up like a big sponge.
An important point here is you don't have to have had carcinoid crisis or flushing in the past. You can have it occur for the first time when you're provoked by the epinephrine in the dental injection or by some other provocative thing, such as being very anxious about a forthcoming surgery or some other problem like that. So that a antecedent history of carcinoid crisis or flushing is not necessary.
This is where the 5 E's come in: epinephrine, emotion, eating, ethanol, and exercise. Thank you. Yeah, if you run a marathon, you can all of a sudden just have a major epinephrine release.
Question for our radiologist. Who should use MIBG versus Octreoscan?
I'm not sure.
I think from my perspective in our practice, we try to scan people with MIBG and with Octreoscan. We then grade their uptake. Those people who have great uptake in both, the vast majority, the biggest experience and the longest information that we have has to come from PRRT with lutetium or yttrium in Europe. So I send my patients to Europe to get treated. I use MIBG therapy with the 131 form in America, A, when there's not good uptake on Octreoscan, or B, after you've already failed all the PRRT in Europe that you can already have. That's how I use it.
My experience has been that the MIBG scanning is not universally available in this country. Many hospitals aren't doing it. And when it is done, the incidence of a positive finding is much less than with Octreoscan. So if you have a choice, Octreoscan would be preferable. It's only when you have a problem, I use it, the MIBG scanning, when the Octreoscan is negative and I want to try again a different way to see the tumors. I've not been very happy with the outcome, so I'm not too impressed about it. The next,
One of the other things about the Octreoscan, it can also predict success of treatment and monitor treatment.
yes,
So from that standpoint, but it's a clinical question that your medical oncologist, surgical oncologist would probably decide.
another question. If hepatic artery embolus outcomes show no significant survival rate, then what is the purpose of doing chemo or bland embo?
Well, no, they can confer prolonged survival, but there are different reasons to do it. One, it might be symptomatic, the functional symptoms, the flushing, or it can be from tumor bulk-related symptoms. So it is a very good treatment for palliation, but it can also confer prolonged survival.
I also have to differ, in my opinion, as far as the influence on survival. The studies that have been reported regarding survival after bland or chemo-embo have been rather restricted to a relatively small number of patients, in addition to which most of those patients were not given any other subsequent treatment. So that apparently with no other treatment to perpetuate the effect, I could believe it may not improve survival. However, there is a series of patients that our group studied and reported in 2003 in whom we did chemo-embo and then continued them with a whole host of other treatments sequentially, both surgery, both, of course, octreotide, sandostatin, and in many cases chemotherapy. And in that group, we had a very much prolonged survival. So I'm very convinced that it does improve survival, and I'm also very pro-chemo-embo, not bland embo. I do agree that the figures show that the beneficial response immediately for chemo and bland are the same, but I also feel that the prolongation or the duration of response is much better with chemo-embo. Again, though, I feel nowadays that the response to radioisotope embo is even better yet, and I strongly favor that. The evidence suggests that its duration of effect is on the average twice as long as chemo-embo, which is, again, itself longer than bland embo.
Richard, say something. I think it's important for everybody to understand that we're dealing with, all these questions are pertaining to metastatic disease to the liver. And once any kind of cancer becomes metastatic to the liver, we're dealing with a systemic illness, not a localized condition. You can use localized therapy in a systemic illness to get palliation, to get alleviation of symptoms, to get some prolongation of life, but you're, in general, not going to affect a cure. You're not looking at curative treatment with localized therapy in a systemic illness. And that's borne by many, many studies that have been shown in all kinds of institutions all over the country in metastatic colon cancer to the liver, where we've tried hepatic resection, hepatic artery infusion of chemotherapy, and all kinds of methods in order to effect a cure on a disease that's spread to the liver, and it just doesn't work. You need to, as Richard just said, you need to supplement that with systemic therapy. It's not going to work alone. So and I agree 100% with what Richard said. If you're going to use any kind of localized therapy, you need to supplement that either with systemic chemo, with biologic therapy, such as the angiogenesis inhibitors, which Richard may want to talk about. He's starting a study that he mentioned to me, and I read about studies where following directed therapy to the liver, the use of angiogenesis inhibitors has prolonged the effect and enhanced the effect of the embolization. So it's important to note that the therapy it's an important part of the arsenal, but it's not going to, in my opinion, not going to work alone, and not going to give you the results that some of you may think you're going to get with it alone. It's just not going to happen.
Thank you. Now, a very practical question, Dr. Waltering. How important is the handling of 5-HIAA specimen? That is, what if it's not kept on ice? What if the appropriate diet is not followed? What if there's no acid, either hydrochloric or boric acid, in the jar, in the container in which the urine is collected?
It is not nearly as sensitive to degradation as serotonin is in the blood. So, you can get probably away with leaving it out at room temperature for an hour or two and not have to restart the whole thing. The diet is very important. The person who taught me more about carcinoid / 5-HIA diets was Monica. She had the greatest list of nuts and kiwis and pineapple and cheese and red wine and all those kinds of things that you have to avoid. And that's still on the carcinoid.org website. And you really do need to do that. And then the last question about the acid, I really don't know. I suspect that if they give you the wrong jug, you probably just need to start over. Let's face it. It's not like you're not going to pee tomorrow.
A word about the importance of the food eaten before and during the collection of the urine. Ordinarily, 80 to 100% of serotonin in the foods you eat will be converted to 5-HIAA and excreted in the urine. Now, since the normal urine output is like 6 milligrams or less in a 24-hour period, and a full glass of pineapple juice can contain as much as 10 milligrams of serotonin, you can double the urine output of 5-HIAA by drinking 1 glass of pineapple juice the day before or the day of the collection, or even eating 1 banana. So diet is important, and it can be thrown off.
See, this is why he's so smart. Because, I've been doing this for 35 years, and I have never heard anybody quantitate how much serotonin's in a glass of pineapple juice. Richard, I got to tell you, I'm always in awe every time you teach me something, because, how much serotonin's in walnut?
Actually,
I'll bet he knows, see? So he can tell you, if you ate 6 walnuts and a glass of pineapple juice to wash them down, you're hosed, dude.
I can tell you an interesting story about walnuts.
I don't want to hear it. I'd be embarrassed.
Because one of the concerns is when you eat serotonin-containing foods, they don't necessarily increase your blood serotonin level. It just gets converted to 5-HIAA by the enzymes in your bowel wall in the process of absorption. But it's been observed that if you eat lots of serotonin-containing foods every day, you can gradually exceed the metabolic capacity of these enzymes in your bowel wall, and you can therefore absorb it as serotonin and pump up the blood levels. And that can throw off the blood test. And for example, I gave a group of patients a daily dose of a quarter pound of walnuts for 6 weeks. They all gained weight, of course. But
Some of them developed a bushy tail.
they increased their blood levels of serotonin as much as 3 or 4-fold, way above normal.
Okay, can I ask a question? And this is a legitimate question that I wonder about. I have a lot of patients who say, I've been told by their doctor that they should avoid certain foods. If you're syndromic, do you modify your diet on a daily basis? And if you don't have symptoms of flushing, diarrhea, wheezing, etc., is there any food that you shouldn't eat?
Probably should not eat lots of nuts of any kind, should not eat bananas on a regular basis. Sporadically, a banana is okay, but not every day. The same thing holds for large amounts of tomato or tomato juice, because that also contains some serotonin. And the same thing holds for pineapple. We issued a questionnaire to a large group of carcinoid syndrome patients, asking them what their experience was with different foods, and we indeed received notations unsolicited that they got more flushing when they ate lots of tomatoes.
Should if you have a carcinoid but you don't have the syndrome, should you change anything in your diet?
I don't know. My judgment would be probably not, unless you're addicted. Like I've had a patient who took a handful of nuts every day, and she had the carcinoid without symptoms, but she pushed up her blood levels, made it difficult to measure what's happening with her tumors. In general, if you don't go overboard in eating these things, it's okay sporadically to taste some nuts or have a banana.
How about alcohol?
No, alcohol should be avoided because it's provocative for carcinoid crisis or flushing, so that it should not be consumed. If you have no syndrome, if you're being treated, or even if you have syndrome and you're completely controlled with octreotide or one of the other slowly emerging somatostatin analogs that are used for treatment, you can have a small amount of wine occasionally, especially if it doesn't bother you. It's not going to provoke the growth of the tumor. The worst it can do is make you get a bit of a flush. And if you try it cautiously and no problem occurs, then you can have a little bit of wine. If you have syndrome which is not completely controlled, you should totally avoid alcohol. All right, let us go on. Another question. Many people first discover their carcinoid in their late 40s or 50s. Is there any correlation between menopause and development of carcinoid? Do you know an answer to that?
I don't think it's menopause. I think it's women have hot flashes, they flush, and they go to their doctor and they say, what the hell's going on? And then they put them on estrogen, and they don't get better, and then they've triggered somebody to think, maybe that hoofbeat isn't a horse. Maybe it is a zebra. And so that's when they look. And I think what Richard says is true. But it's all due to suspicion. You know, sort of like the motto of this group. If you don't suspect it, you can't detect it. And menopause makes you know that there's something fishy. And that, so people start to look for it. I think that's probably it.
I think that, in my experience, there's been no connection with menopause. Here's a question. What is the difference between sandostatin and lanreotide? Since they both inhibit human growth hormone, are there any negatives to not having human growth hormone? I presume it means a high growth hormone level.
If you look at the 3 commercially available somatostatin analogs, lanreotide, vapreotide, and octreotide, and you adjust for their potencies, they're basically, you pays your money and you takes your pick. There are clearly some differences that we're finding in the people who have LAR and the formulation. Anybody who's ever had LAR or given it to their mom with a tiny hiney like I have, knows it's a booger to mix. And you have to be smart to mix LAR. The one big difference is Somatuline Depot comes pre-mixed. It's like dippity-doo in a syringe. The syringe is likened to Moby Dick and Captain Ahab. It's a small needle, but it's pretty fat around, and it's sort of an imposing-looking needle. Not that the needle on the LAR thing is not imposing as well. But I think the biggest difference between them is one, you got to mix, and it's a booger to mix, and you can clot it and clog up the needle and have to have another dose. And as you know, Novartis will give you, if you clog up the needle and have to throw away the dose, there's what's called the HERO program, and that means that they'll replace for the physician that dose and not charge you for it. So that's important to know, that if they throw it in the garbage can, you ought not to get a bill for it. They can get a new one for you. But the potency, what they do, how they control symptoms, I think they're identical. Other things that we're learning, we now probably have 30 or 40 people on lanreotide, Somatuline Depot, and I think, it takes about 120 milligrams twice a month to get you up to the high levels that you guys know I like. And 2, the Somatuline Depot people will tell you it takes 4 months to get up to steady state. That's not true. It takes probably 6 months to get up. So it's a slower thing, but then once you get up there, it's a little bit smoother, I think.
Craig, here's a question for you. Can yttrium-90 or chemoembolization be done if a patient is allergic to radiographic iodine-containing contrast dye?
Oh, good question.
Contrast allergies are rarer and rarer, but if you have a true contrast allergy and it's anaphylaxis, it could be a problem. We do pre-medicate with steroids and Benadryl for reactions, and I have not seen a contrast reaction in 15 years, I don't think.
Okay. Also, can we dilute the contrast and use a smaller amount?
No. If you have a true contrast allergy, even 1 cc of contrast can set it off.
Well, let's extend that question. What if you have impaired renal function?
Okay. Impaired renal function, depending on how impaired, we have been able to tune patients up with our nephrologists, and we have given patients with renal insufficiency where their kidney function is not normal and their creatinines are elevated, and even with very high doses for patients that require any kind of cerebrovascular interventions or high volume peripheral interventions, it's very unusual these days to see patients, in our experience, go into renal failure from contrast-induced nephropathy.
Can you dialyze off this stuff? Could you do the arteriogram and then run them down to dialysis and get it out of their blood?
I don't know.
I don't know.
In rare circumstances, we have done something like that, but there's really no way to sort of prevent that with one dialysis session or two. But again, unless you are really on the verge of dialysis, it's very unusual these days to go into acute renal failure that requires long-term hemodialysis. Now, you may go into a transient renal insufficiency, and you may need a few sessions, but they wouldn't do it prophylactically, a hemodialysis session. They would wait and see what happens. And generally, it takes at least 72 hours to figure out what's going to happen.
Gene, 2 questions for you. How can we get Chinese sweet leaf tea?
Can't. That's simple.
All right, I'll ask a question that wasn't written there. How do we get the raspberry powder?
Oh, the black raspberry powder. They had a terrible black raspberry season last year, apparently. And guys, I have absolutely no financial ties to the black raspberry world, other than I love black raspberries. It's my favorite pie. Anyhow, the 2 places are Stokesbury Farm in Ohio, and the other place is, I think, called Nutrifruit out of Portland, Oregon. The stuff is expensive. I mean, that's why I ask people, to think before you do it and see if you're one of the people whose tumor has been tested in the assay. I mean, it's like $10, $15 a day if you do a gram per kilo per day. Steiner and the guys at Ohio State use about half of what we use for their head and neck patients and their Barrett's esophagus patients. But again, Stokesbury Farm in Ohio and Nutrifruit, both of which are on the internet. If you were at the conference, we gave you the little packets. The Nutrifruit people gave us the packets of black raspberry so you can taste it. It's very tart. It's not very sweet. How do you mix it up? A lot of people ask me that. I tell people, put it in like some iced tea, stir it up, let it sit overnight, then filter out all the little seeds and stuff with like Bed Bath & Beyond, one of those little metal coffee filter kind of things that you can put in the wash machine. And remember, do not get it on your clothes, man. This stuff will, if you get it on a white shirt, just throw it away because you ain't getting it out.
How can we get gene testing done to determine specific pathways? And is there a blood test is this a blood test or a tumor sample test?
The genetic testing for carcinoids, islet cells, MEN1 is a guy named Steve Marks at the National Cancer Institute. There is a protocol there, and it's basically your genome, which is a buccal swab. They swab the inside of your mouth. What we're trying to do is find out the gene differences between primary tumors, lymph nodes, and liver metastasis, and to see how they respond. That's going to be on tumor tissue, and again, that's going to be on fresh tumor tissue that we have cryopreserved. And again, when we get that up and ready, that'll be a free test. We'll do that for free.
Can neurokinin A levels be tested on tumors removed 10 years ago?
No.
This is a blood test, not so much a tissue test. And neurokinin A, pancreastatin, and substance P are all blood tests which are not available in New York State at present. They were available up until a couple years ago, but there are some problems with licensing the laboratory that does this commercially, which is...
Same with octreotide levels and lanreotide levels.
Yeah. ISI in California does it, and it can be obtained in any other state in the country. Hopefully, it's going to come back to be available in a year or so, but I'm not holding my breath on that. What I do in general is send my patients for these tests to a colleague in Connecticut or New Jersey or some nearby state where they will just order it on their script and then it gets done.
Remember, even a dentist can order a blood test. So, you think, oh, I don't know a doctor, have your dentist in Poughkeepsie, New Jersey do it.
Dr. Zaks has a question to answer.
Were you referring to? Go ahead, read it. Would you call your flight with Dr. Werner a heart risk factor? No, actually, in all seriousness, I've flown with Dick a number of times, and he has a very calming effect on me. And I think on almost all the others. I know my wife got a little queasy one time, but my experience is a very calming one when I've flown with Dick.
We've only got time for one or two more questions.
One in the back, Bob?
By the way, we're going to have another question and answer session this afternoon, and I'll be available also for personal confrontations. If your tumors were removed,
Confrontations.
if your tumors were removed 1 year or greater ago, and you can't test for treatment effect, and I don't know what's meant by that, why you can't test for that, are you left with just a hit-and-miss treatment plan?
I think what they're talking about is like chemosensitivity or chemoresistance. If you don't have fresh tissue, then you have to go on what we found by the herd. And I think Dr. Werner has been doing this since Noah was sawing the boards for the ark, and he would choose what? 5-FU,
Again,
Timidar for the average person?
The question really comes down to if you have no other guidelines except that we know what kind of tumor it was, what'll our choice be? Okay, that depends upon the aggressiveness of the tumor. If it's a very aggressive, rapidly growing tumor, then we're going to look for cisplatin or carboplatin and VP16. If it's a foregut tumor or a pancreatic tumor, we might consider a streptozotocin-based regimen, but nowadays we're also looking into the use of RAD-001, known commercially as Afinitor, and approved by the FDA for renal cell carcinoma, which therefore allows you your doctor to prescribe it off-label. You may have trouble with your insurance people paying for it, but sometimes with a convincing letter of necessity, that will be accomplished. If it's a hindgut tumor, that is one arising in the distal colon or the rectum, then all bets are off because there is no preference and therefore and the experience has been rather slim in the response to chemotherapy, in spite of the fact that these tumors are more commonly encountered now than they used to be. However, we can do some things. For example, we can do an octrio scan and see if the tumor lights up. If it does, it certainly makes that tumor amenable for treatment with octreotide, sandostatin. Also, we can try a colorectal chemotherapy regimen, such as Folfox or one of those similar routines, which sometimes are effective. So that there are possible ways of treating, even when we don't have more specific guidance. I think we're up to our time limit now.